Hello, my name is Michael Silberbach. I'm going to speak with you today about cardiovascular disease and Turner syndrome, incidence, outcome, monitoring, and when to worry. I am the chairman of the Turner Syndrome Research Registry Scientific Advisory Board, and it's quite an honor for me to speak with you today. I'm sure most of you know the features of Turner syndrome, and just to refresh your memories of that, they're listed here. Today I'm going to focus on cardiovascular disease in Turner syndrome. But for first two vignettes that I think will frame our discussion. Joy was a 15-year-old member of her gymnastics team, had Turner syndrome, complained of chest pain on a Sunday morning, called her pediatrician, was referred to her cardiologist, who gave her antacids, and on a Wednesday, after persistent chest pain, died suddenly with an acute aortic dissection. Caitlin here was married, has Turner syndrome, known to have an aneurysm of her left subclavian artery, and approached her obstetrician to request artificial reproductive therapy. She was approved for that, was implanted with 2 eggs, and died at 36 weeks gestation, her 36 weeks into her pregnancy from an acute type B dissection. So, you know, just it's a sobering story, but not unheard of, as you will hear. So the hallmark of the cardiovascular issues related to Turner syndrome are these 3 areas: bicuspid aortic valve, aortic stenosis, systolic blood pressure elevations, and significant aneurysms of the aorta, including the ascending aorta, aneurysms of the left subclavian artery, and descending aorta, and the associated elongation of the transverse aortic arch. To get some idea of the incidence of aortic dissection, I think the best study was in the Danish registry by Klaus Gravholt. And I think it's notable that if you look at aortic dissection per 100,000 years, TS women years over age groups, the average age is around 30 years of age. If you average it over the entire lifetime, it's about 40 per 100,000 Turner syndrome years. We contrast that with the non-TS female population, where it's about 6 per 100,000 years. But I think the important point here is that if you average it over a lifetime, you don't see such an increase in incidence, maybe 6-fold. But if you think that, if you realize that death at Turner syndrome or aortic dissection in Turner syndrome averages at the age 30 years, when it's vanishingly small risk, we're really approaching an infinite type of risk in 30-year-olds, as opposed to the general population, where the IRAD studies show the average age is around 67 to 70 years. So in summary, congenital cardiac malformations are quite common in Turner syndrome. 25 to 50% have bicuspid aortic valve, 15% have coarctation of the aorta. And to put this into perspective, bicuspid aortic valve prevalence in monosomy X is 50 to 150-fold that of, I guess you would call it disomy X females. This relates to the recommendation in the Heart Association scientific statement that simply finding a bicuspid aortic valve in a female warrants testing for Turner syndrome. Now, in terms of outcome, aortopathy and aortic dissection and rupture is probably the most significant risk for the young individuals with Turner syndrome. And most importantly, and that's why we focus on this, is where the treatment and the decision-making is different from the general population. While hypertension, stroke, and ischemic heart disease are also common in Turner syndrome. Their treatment, assessment, and management really is not different than the general population. So we're going to focus on aortopathy, aortic dissection, and rupture. To get an idea of the burden of cardiac operations in Turner syndrome versus the non-Turner syndrome population, we studied 432 individuals with Turner syndrome using the Midwest Consortium database put together by Dr. James Moeller. And what we're looking at here are the predominance of left heart lesions that are present in Turner syndrome. And the numbers here on the right, on the right hand of this slide are the odds ratio, and the asterisks represent significant difference. So for coarctation in particular, operations is up to 17-fold that of the non-Turner syndrome population. But other left-sided disease is also in great predominance: hypoplastic aortic arch, aortic aneurysm 5-fold, hypoplastic left heart 4-fold, aortic valve disease. And of note, other cyanotic disease is 10-fold less in the Turner syndrome population. So this is to say that there is quite a burden of Turner syndrome operations compared to the general population. And this translates into a significant probability of death in Turner syndrome.
I couldn't quite hear you.
And this study by Shoemaker et al. In England looks at the probability of all-cause death in Turner syndrome compared to that of the general population. And it is significantly about 2-fold higher. But most importantly, from our point of view, is if you look at circulatory deaths in Turner syndrome, it is equal to the probability of all-cause death in the general population. Again, to my point that there's a significant burden of cardiovascular disease in the Turner syndrome cohort. So what are the risk factors for aortic aneurysm and dissection in Turner syndrome? Misty Carlson and I did a literature review some years back, 85 40 publications, 85 incidences of aortic dissection. And we found that bicuspid aortic valve and hypertension were the major predominant findings. And if you look at all dissections in which they looked at these factors, 75% had either congenital heart disease alone or congenital heart disease and hypertension. 14% had only hypertension. And an important subgroup of 11% had no obvious risk factors, but also suffered from dissection. So this is my most important slide, and I forgive you, please forgive me for it being so busy, but I'll walk you through it as best I can. We are considering the aortic size index in 13 individuals who had echocardiograms prior to the aortic dissection, and comparing that to the 458 individuals who did not have dissection over the lifespan. Just to remind you, the aortic size index is the ascending aortic diameter divided by the body surface area at the level of the right pulmonary artery. And what is immediately notable is if you look at the aortic size index over the lifespan up to age 15 years, the aortic size index is quite large. This suggests that in children, they essentially grow into their larger aortas. After the age of 15 years, it's a fairly good index for normalizing aortic size to body size. If you look at the group that had aortic dissection, their echocardiograms prior to dissection, all had aortic size index equal or greater to 2.5 centimeters per meter squared, with this one notable exception. This is important because if you look at the data from Davies, who looked at other genetic aortopathies, the risks for aortic dissection did not get significantly high until the aortic size index was 4, indicating that in the non-TS genetically triggered population, the size of the aorta at the time of dissection was much larger compared to Turner syndrome. So because of this relationship between the aortic and body size under the age of 15, it is why we recommend using Turner-specific z-scores in those less than 15 years of age. This is a busy slide, but in terms of monitoring, as recommended by the scientific statement of the American Heart Association, now let me just say that we're basically dividing into when they're less than 15 years of age or older than 15 years of age, whether they have a concomitant risk factors. And then a Turner syndrome specific z-score of less than or greater than 3 is an important indicator. And in the older age group, all the same except we use aortic size index. So in conclusion, I would like to say that aortic dissection occurs at significantly younger ages and at smaller diameters in TS versus the non-TS population. The disease burden of left heart obstructive disease and aortopathy is significantly higher in Turner syndrome than in the general non-Turner syndrome population. And Turner-specific aortic z-score should be used to assess risk for those under age 15 and aortic size index for those who are older. And I'd finally like to make a plug for the Turner Syndrome Research Registry, which I hope you all become interested in, involved. And this is sponsored by the Turner Syndrome Resource Network, or the TRN. Thank you very much for your attention, and I hope we can talk about this later.